want to welcome you all on behalf of the California Healthcare Foundation to our briefing on data matching to streamline eligibility enrollment under the Affordable Care Act. We're so pleased that so many of you have come out to hear about this. I have to admit, I personally was a little concerned about how much this very technical information would have broad appeal, and I'm delighted to see that I was wrong or didn't need to have that concern, and I will never again underestimate just how wonky our California health policy stakeholders are. So I'm glad you're here. My name is Catherine Tier. I'm a senior program officer with the Foundation's Health Reform and Public Programs Initiative. I think most of you know the California Healthcare Foundation and our work. We're an independent philanthropy based in Oakland, committed to providing ideas and innovations to serve all Californians and working to improve the way care is delivered and paid for here in the state. Just a few quick words on the format for today's presentation. Stan Doran here will present his research for approximately 45 minutes, and then we'll have a short response from our colleagues Renee Malo and Robert Sugawara from the Department of Healthcare Services, and after that we'll go into a question and answer period for the last 20 minutes or so. The California Healthcare Foundation has long been interested in looking at ways that eligibility determination and enrollment into public programs can be streamlined and modernized to be made as easy as possible for consumers so that they aren't deterred by long delays in becoming eligible and enrolling in programs or by burdensome paperwork requirements. We also believe that in addition to helping consumers, streamlining can help the state with the potential to significantly reduce administrative costs. And the Affordable Care Act shares this vision of bringing enrollment into the 21st century. The ACA's requirements of building a first-class user experience for enrollment through state exchanges is well known. One of the other requirements of the ACA is what we're here to discuss today, the requirement that the states use existing data sources to establish applicants' eligibility for services whenever possible. And what the law says is quite clear, but exactly how that is to be put into operations is significantly less detailed in the statute, and that's why we're here today. In order to try and get a little bit more specific about what this would look like in practice, we turned to Stan Doran and his colleagues at the Urban Institute in Washington, D.C. And Stan has some great ideas about how data matching can be used to streamline applications and renewals in Medi-Cal and to identify eligible individuals applying for exchange programs. The analyses that Stan's going to provide today combine the rigorous analysis and the policy smarts for which Urban is very well known. So we're delighted to have Stan here in person to walk us through the first two pieces of research in this larger project and to talk to you about their implications for California. Stan has worked for more than 25 years at the state and national levels on low-income healthcare issues. Before he joined Urban Institute, Stan was a senior policy analyst at the Economic and Social Research Institute, health division director at the Children's Defense Fund, director of the Health Consumer Alliance here in California, and managing attorney at the National Health Law Program's Washington office. He's now focused on state and national implementation of the Affordable Care Act at the Urban Institute, where he's a senior fellow. And we are delighted to have him. So without further ado, I'll turn it over to Stan. Thank you.
Thanks, Catherine. Yeah, it is a wonderful, it's a delight to be here. I grew up in California, got my start working on healthcare issues in Los Angeles at the National Health Law Program during the mid-1980s, back in the Deukmejian administration when dinosaurs walked the earth. And so it's really a pleasure to be here and to be with you all who are putting California once again in its rightful place in the front ranks of American states, cutting new paths towards solving health dilemmas that are facing the rest of the country. So it's a thrill to be here with you today. I'm going to talk about three things. How data can be used to streamline enrollment and retention, financial eligibility for Medi-Cal, and then finally employer-sponsored insurance and subsidies in the health insurance exchange. Now, the project that but before I do any of this stuff, I need to say a few thank yous. One is to the California Healthcare Foundation for recognizing the streamlining power of data and for supporting our work, not Not many foundations are interested in supporting this kind of work, have the kind of vision that Catherine and Sam Karp and Mark Smith and their colleagues at the foundation do. But we're so grateful to them and to Len Finocchio at the Department of Healthcare Services, who came up with the idea for this project about a year and a few months ago. If you like what you're about to hear, you should give thanks to Len and to the foundation for their great ideas. If you don't like it, you should blame me for my poor execution. So thanks to them, and then finally to my Urban Institute colleagues, Matt Butkins, who heads our modeling team, and his group of mathematicians and economists who crunch through the numbers and bring you the results that I'm going to speak with you about today. So to step back in time for just a moment, the traditional way of doing public benefits is very paperwork intensive. It's been this way since the 1950s, really. The consumer who wants assistance comes in, fills out a piece of paper, the application describing the consumer's circumstances, presents pay stubs, employer affidavits, immigration documents to document eligibility. The social services caseworker reviews the documents, applies the rules in the manual, and then the person gets on if they're eligible and they pass all those requirements. Then when the eligibility period is coming to the end, the state sends another form out to the consumer. Fill this out, tell us what your circumstances are now, attach more documentation, current pay stubs, et cetera, send it back. And if any of those paperwork requirements doesn't get fulfilled, the person loses coverage or doesn't enroll in the first place. Now, in the 1950s, there wasn't much you could do about it. You had to determine eligibility, you had to verify the person was eligible, and there was nothing to rely on but paper. But now, we're in the 21st century. And now, government agencies and private vendors have increasing amounts of information about each of us. And now, the information technology is advanced to the point that accessing that data and processing it using computer business rules rather than human beings looking at manuals and pulling out calculators and figuring it out, it's now much cheaper, it's now much more reasonable and plausible than it was in the past. So the ACA, the Patient Protection and Affordable Care Act, says, let's see if we can do something about moving eligibility determination into the 21st century. People begin the application process by attesting to the circumstances of their household under penalty of perjury. But if we can verify eligibility based on a data match, that's enough. Why require, in other words, if the government already knows, if it already has access to information from which it can determine your eligibility, why should it waste your time asking you to provide extra paperwork to tell the government what, in effect, it already knows? And the idea is, if we can do data to see whether you're eligible, great, end of story. If we can't, then you have to come forward and provide documentation. That's the basic notion. And the hope is that when consumers have fewer burdens they have to shoulder in order to apply, more who are eligible will apply and participate in the program. The hope is that state administrative costs will drop when instead of paying human beings to look at a piece of paper and look at a manual and pull out their calculator, you have computers exchanging data, you'll save money. And the hope is that you can have more accurate eligibility determinations when you have less likelihood of somebody transposing digits or getting confused about, is this person being paid once every 2 weeks or twice a month? So the hope is really to simultaneously increase participation, cut waste, and improve program integrity. So the fundamental insight that all of this embodies comes from a much broader area of thought, behavioral economics, which has been teaching us how hugely important small paperwork burdens are in determining the number of people who actually take advantage of benefits for which they qualify. And it's not an issue of low-income households and health coverage, it's an issue of human nature. So with retirement savings accounts, for example, if I have to go out and establish an IRA, I'm eligible, right? But there's only a 15% chance that I'm going to actually fill out that paperwork. If I start work and my employer offers me a 401k account offering the identical tax advantages for retirement savings and says, Stan, fill out this piece of paper and we'll set up a 401k for you, there's a 33% chance that I will do that. Identical tax benefit, more than double level of participation due to less paperwork. If my employer says, Stan, unless you file this form opting out of a 401k, we're going to set one up for you. 90% participation when you shift the default. So paperwork is powerful in determining levels of participation. Now, we have a couple of examples of where programs have shifted from a paperwork-driven 1950s style eligibility determination into a 21st century data-driven style. And one comes from the Bush administration, the George W. Bush administration, Medicare Part D, prescription drug coverage, low-income subsidies, and the way they administered this was just a triumph. It left seniors happy and dancing, as you can see there on the screen. And the idea was they did data matches with state Medicaid programs and the Social Security Administration, and if the data matches showed that a Medicare beneficiary received Medicaid last year or supplemental security income, cash aid for the elderly, blind, and disabled last year, that person automatically got low-income subsidies for Medicare Part D, even though in some states Medicaid's a little bit more generous. But that's all right. So that person would automatically get low-income subsidies. If they didn't pick a plan, one would be picked for them. Now, if the data was not enough, then you could come forward and submit a traditional application to the Social Security Administration. Well, what did we see? In less than 6 months, almost 3/4 of eligible beneficiaries were signed up, 74%. And the vast majority of those folks hadn't filled out application forms. They qualified based on data. Now, to understand the significance of this accomplishment, contrast that with the story of CHIP. CHIP, right now, Children's Health Insurance Program, Healthy Families, at least until recently in California, along with Medicaid, has been one of probably the country's most successful program in enrolling eligible people. 85% of eligible kids nationally participate. So it's been quite a success. But 5 years after the program was established, only 60% of eligible kids were signed up. Second example, food stamps, right? There's nothing more basic. There's no need more primary than food. And yet 2 years after the pilot program of food stamps was taken nationally, 31% of eligible people were signed up. So to put this, so for CMS to get 74% of eligible seniors signed up in less than 6 months after the program began is just a mind-boggling accomplishment. And the only reason they were able to do it is they used data matches to determine eligibility. Here's a second example, Louisiana, which many of you may not think of as a cutting-edge state for progressive health policy, in fact is in many ways. So they don't cover very many parents, but they do cover kids up to pretty high percentage of income of a federal poverty level, like every other state. And here's how they work renewals. At the end, like the kid goes through 12 months, right? You're at month 11. We're going to renew eligibility. They don't send that piece of paper to the family as the first step. They do. The first thing they do is they look at data. They do a data match with the SNAP program, CalFresh here. They look at child support enforcement records. They look at state workforce agency records. And they say, can we say, based on this data, not is eligibility absolutely 100%, gold seal guaranteed right, but is it reasonably certain that this child continues to be eligible? And if so, the child is continued and the family doesn't have to do a thing. Now, if it turns out that the information is not enough to redetermine eligibility, they don't send a piece of paper to the family. They try to contact the family and get the family to provide the missing information only, not everything from A to Z, but just the information that's needed for eligibility over the phone. For some reason, people find that easier to do than filling out forms. I sure do, and the same is true of people in Louisiana. Only if everything else fails is the family sent paperwork it needs to fill out. Now, what's the result of this policy been? 75% of all kids are renewed administratively in Louisiana. Less than 1% lose coverage for procedural reasons because they don't provide necessary paperwork. Less than 5% lose coverage for any reason. These are folks whose incomes go up and they are no longer eligible for CHIP. That's the basis of it. Now, to understand the magnitude of this accomplishment, let's put that in context. Nationally, 28% of Medicaid and CHIP kids lose coverage every year. And 45% of those children are still eligible, and they don't have any other source of insurance, but they don't fill out the paperwork and they don't renew. For adults, it is so much worse. For adults, if you look at adults who are always eligible, their circumstances are very stable, 29% of them lose Medicaid every year because they don't complete the procedural requirements. One study looked at adults on Medicaid whose incomes went down over a 2-year period. More than 50% lost Medicaid, even though they were more eligible, not less eligible. So the fact that Louisiana was able to virtually end procedural renewals and cut terminations, and cut terminations down to 5% is just an extraordinary achievement. Now, you may say, well, that's very good that's nice, good and well for the Big Easy, but they're loosey-goosey down there. Here we have to be a little more careful with our money. Louisiana just completed its federal payment review, and not only are they the nation's most efficient program and most consumer-friendly program, they are the nation's most accurate program. The federal payment error rate was 0.1%, less than 1/10 the national average. In the entire sample for the federal payment review, they took a whole bunch of cases, statistically valid sample. There was only one mistake in eligibility that was done for all those folks. Not one person was wrongly granted eligibility. One person was wrongly terminated. That was the only mistake. And it's not the first time Louisiana has done much better than the rest of the country. So what Louisiana shows is you can streamline and actually have better program integrity, not worse program integrity. So, so it's a very exciting. So let's move now from the Bayou to Los Angeles and Oakland and Yolo County and Amador County and talk about financial eligibility for the Medi-Cal program. Now, there are some new rules for eligibility starting in 2014, and all of this discussion is premised on 2014 rules. As you know, states will have the option to expand Medicaid eligibility up to 138% of the federal poverty level. How many people think of it as 138? How many 133? 138? 133? You say potato, I say potato. The deal is it's 138 gross, then you subtract 5 FPL percentage points, and then you have it's 133 net. Does that make any sense? Did I help? No, I didn't help, but at least I kept you entertained, and that's all. That's my goal. So the idea is, states do have some options. However, once you decide, okay, we're going to do the expansion to 138% FPL, you have to figure out how do we determine your income. And there's two approaches. States can determine income on a monthly basis. It's January. You're applying for Medi-Cal. What's your income in January? If you're below 138% FPL in January, you're eligible. That's the end of the story. Or states could do it on a projected annual basis. Based on what we know about you, what does it look like your income is going to be for the coming year? There's some question about whether you can do projected annual income determinations at the initial application, but you can certainly do it at redetermination. Now, that's on the eligibility standards. What about how do you process applications? And the key for the processing of applications and electronic verification is compatibility. It's not just about romance, it's about finance. The two are actually pretty linked. You know, what's that old song from the 1940s, romance without finance is a nuisance? Oh, baby, give me some gold. You know that song? Everybody knows that song, right? So I'll sing it afterwards if you want. So the idea is, if I come forward and do an application and I say under penalty of perjury, this is my income, and then you, the state, do a data match, and the data match is reasonably compatible with my attestation, that is sufficient verification. Not 100% certainty, reasonable compatibility. And the CMS says states have a lot of flexibility in how they define reasonable compatibility. However, if my attestation is of income below 138% FPL and the data show income below 138% FPL, that's enough. That makes me eligible. You don't ask me for pay stubs or an employer affidavit or anything like that. So if I say, oh, my income's at 40% FPL and the data show it's at 100% FPL, it doesn't matter. They're both below 138 and I'm eligible. That's on the application side. Now, on the renewal side, basically what Louisiana has done is being taken nationally. Renewal is a good thing. We all want to be renewed. And what the regulations say is that if a Medicaid agency can redetermine eligibility based on reliable information, it must do so without contacting the individual. And how does the process work? So the way it works is somebody's coming up to their 12th month of eligibility. It's time to renew them. Before the state contacts them, it goes and searches all of its available databases, and if based on reliable data it says, yeah, this person's eligible, they send the person a notice. So it's like, you know, dear Mr. Smith, it appears to us from your records that your income is XYZ. If we're wrong about this, you have a legal duty to correct us, and if you don't, we're going to find you and throw you in jail. So, you know, let us know. And so, but if Mr. Smith doesn't respond, the default is continuation of coverage. It's about default arrangements. The absence of consumer response means the coverage continues. If Mr. Jones doesn't make the correction, the coverage continues. Now, in some cases, that's not going to be possible. In some cases, you really don't know from the data whether the person continues to be eligible. In those cases, you ask the beneficiary for information, but you can't ask them for every little bit of information under the sun. You have to hone in on the things that you really need to know to redetermine whether they're eligible. That you can ask about and nothing else. So those are what the new rules are. Now, all of that may seem clear, but as we got into this work, it became clear that there were things that were unclear. These are the known unknowns, to go back to the Bush administration one more time. So we know from the regulations that data showing income below 138% FPL is reasonably compatible with an attestation of Medi-Cal level income. So all make sense to people? Okay, excellent. So, but how long ago does that data have to be? 3 years ago below 138% FPL? 2 years ago? 1 year ago? Well, We don't know the answer to that question, though we do know the state has the flexibility to come up with a good definition of reasonable compatibility. So it seemed to us, for purposes of our analysis, that suppose the data match makes it more likely than not that you are currently eligible. That, just by the meaning of the word, seems reasonably compatible with an attestation of current eligibility. We also want to say, well, let's suppose the state wants to be a little stricter about it, and they want to say, okay, we're going to insist that that data match show at least a 60% likelihood in order for us to say, yes, it's reasonably compatible. Remember, it's not the gold standard. It's not, oh, the data by itself absolutely has to prove it. The person has come forward under penalty of perjury, describe what their income is, and the question is, how good enough does the data have to be for reasonable compatibility? So our thought was 50 to 60% range would be a logical range. And now we've been pressing CMS on this, and like millions of other people all around the country, we have not gotten definitive answers. We've gotten positive informal indications, encouragement to talk to states about this, reminders of the fact that the regulations say states have a lot of flexibility in defining reasonable compatibility, but we do not have, a letter from CMS saying, here's the rules in this particular regard, in this particular detail. Now, what about the question about renewal? The regulation says information has to be reliable, and if it's reliable, then you renew administratively, and the default is enrollment unless the person corrects the statement that you provide. But how likely must eligibility be? Again, we don't get any answers from the regulations. Not surprising, because this is our study is the first time, as far as I know, that people have looked at these issues in probabilistic terms. So we thought it's reasonable to say, a state could say, you know what? If the data match shows more than an 80% likelihood of eligibility, we'll set the default at renewal unless we hear otherwise from the consumer. Or the state might want to be stricter and say 90% likelihood of continued eligibility for administrative renewal. So with that in mind, we tried to take a look at the data and say, okay, what's going to make sense? Now, what did we do? We looked at data from the Survey of Income and Program Participation, SIP, which follows households over time. And so we said, okay, we're going to see everybody's story in year one. We know everybody's story in the survey in year one. What happens to them in year two? If they had income of X in year one, what was their income in January through April of year two? In May through August, what was their total income? And that way, we were able to assess the relationship between prior year income and current eligibility for Medi-Cal. So what do we find? Suppose you're somebody who had no income at all in year one. What's your story in year two? Well, not surprisingly, January through April of year two, 95% of those folks are still eligible for Medi-Cal. Some of them may have gotten married, some of them may have gone to work, may have won the lottery, but most of them are still eligible. As time goes by, more people get a job, more people have circumstances change. By the last 4 months of the year, only 90% of these people are eligible for Medi-Cal. Well, that's still a lot. Now, if you look at the annual eligibility period, 96% of the folks who had income at zero last year have income at Medicaid levels this year. You'll notice 96 this is a smart crowd, I know, 96 is higher than 95, and you guys all picked that up, I'm sure. And one of the themes that we saw is that when you determine eligibility on an annual rather than a monthly basis, it becomes stabler. It's not as subject to the month-to-month variations, and therefore 1 year's income becomes a little bit more predictive of what current eligibility is. Now, what happens if you earned a little bit more last year? If I earned between 1 and 80% of FPL, a lot of folks in this category, even these folks, January through April, 90% of them are still eligible for Medi-Cal. By the time you reach the last 4 months of the year, 80% are eligible. If you determine their eligibility on an annual basis, 93% are eligible. Is this making sense to people? Okay. You're not going to be surprised to see these numbers shrink. If your income is a little higher, 81 to 100%, still far more, 71 to 80% likelihood. If you go up higher, still 76 to 67. Even the very highest chunk of people that we looked at, the highest strand on the layer cake, 120 to 138% FPL, we were surprised to see that in the first 4 months of the year, 2/3 of those folks are income eligible for Medi-Cal. And by the last 4, 56% are still eligible for Medi-Cal. So what does this mean in terms of Medi-Cal's business rules? Now, what do I mean by business rules? That's how you program the computer, so that the person goes to the Mrs. Gutierrez goes online, she says my income's XYZ, the computer pulls all this information about Mrs. Gutierrez, and the business business rule says, here's what you do with this information. Given all this information, you know Mrs. Gutierrez is eligible, send her a Medi-Cal card. Given all this information, you need to know X, Y, and Z from Mrs. Gutierrez. Ask her those questions. Ask her X, ask her Y, ask her Z. Those are the business rules that run the computer. So what is this information that we've been gathering tell us about what the business rules are for initial applications? Well, let's suppose, for example, California wants to be kind of a stickler. California says, we're going to make sure that the prior income creates at least a 60% likelihood of current eligibility in order for it to be reasonably compatible with an attestation of Medi-Cal level income. So what do the rules have to be? Well, if Mrs. Gutierrez is applying in January through August, what the computer does is it checks to see, was her income last year below 138% FPL? If it is, there's more than a 60% likelihood that she's eligible, right? Even if she's at 120 to 138, through August, it's 60% likelihood. So you meet that 60% test, it's verified. She doesn't have to provide pay stubs. If it's the last 4 months of the year, however, Mrs. Gutierrez would need to have income below 120% of the federal poverty level in order to meet that 60% threshold, because if she's above it, there's a 56% likelihood, not quite a 60% likelihood. So those would be how California would set those rules. Now, how many people could qualify, have eligibility verified based on prior year income using those rules? Quite a lot, it turns out. Between 66 and 79% of all Medi-Cal eligible consumers could have their eligibility verified based on prior year data using these kinds of rules, depending on what the month is and which of the business rules California applies within this set. That is an extraordinary number. Not everybody. You're still going to need pay stubs from some folks, employer affidavits from some folks, but for the bulk of people, prior income data could be enough. And that means that for more than 2/3 of Medi-Cal beneficiaries, all we need to do is have the consumer attest under penalty of perjury to Medi-Cal level income, conduct data verifications, and that establishes financial eligibility. Don't have to ask for paperwork for consumers. It means higher levels of enrollment. It means much lower state administrative costs. It's just an extraordinary opportunity. Now, you may ask, how many of these folks file federal income tax returns? And that'd be a good question. We looked at that a few years ago, and we're surprised to find that among the uninsured as a whole, 86% file federal income tax returns. And among the poor uninsured, below 100% FPL, 75% do. Many are not legally required to file, but they do so anyway to get the earned income tax credit and now the child tax credit. So for a lot of folks, even if their income was low, you're not going to find income tax records to verify eligibility, but for most you will. So it's very exciting. Now, what rules would you apply for administrative renewals? What rules would you apply to say, well, we're going to be like Louisiana here? So suppose California said, you know what, we're going to require at least an 80% likelihood of current eligibility in order to set the default at renewal if we don't hear back from the consumer. If it's an 80% likelihood, and suppose California said we want to redetermine eligibility on an annual period, you would say, Mrs. Gutierrez, she's been around for a year, it's now month 11, okay, it's time to renew her eligibility. Before you contact Mrs. Gutierrez, you do all the data matching, you see, okay, last year she had an income of 100% FPL, that's below 120% FPL, that means there's more than an 80% likelihood of current financial eligibility, and so we can administratively renew Mrs. Gutierrez. So we send her a form. We say, Mrs. Gutierrez, it appears to us your income is XYZ. Please let us know if that's not right or if things have changed. If you don't let us know, we're going to catch you and throw you in jail. And then if you don't hear back from Mrs. Gutierrez, her eligibility continues. So those would be the rules that you could apply for administrative renewal. Now, how many people could you renew administratively if you take this approach? It depends. Here, state policy choices have a lot to do with the answer. If it's done on an annual basis, if that's how you measure income, because it's much more stable, you could administratively renew between 60 and 71% of Medi-Cal eligible consumers. If it's on a monthly basis, a lot depends on the month when their application happens to come up. If it's January through April, you'll be able to do this for 55 to 64%. Later on the year, depending on how likely you're insisting the current eligibility to be, that you may only be able to renew administratively 10 or 11%. So the policy implication is that you can dramatically cut back on what has been one of the country's biggest problems in Medicaid. People, it's like you pour, Ruth Kennedy, who runs the Louisiana Medicaid program, talks about pouring water in the top of the bucket, and then there's a hole in the bottom of the bucket. You get people signing up, and then you get people dropping off, and then 2 months later they come and apply again, and you have to reprocess their eligibility. A lot of that problem would go away under the Affordable Care Act if states implement these approaches. And the hope would be not only fewer terminations of eligibility, but much cheaper determination of eligibility. We did a study of one of the things Louisiana did, express lane eligibility, where they renewed automatically based on SNAP records, CalFresh in California. For every dollar they put in investing in IT, they got, 20 some odd dollars of savings. They saved $1 million in initial applications in 1 year, tens of millions in renewals. I mean, it's unbelievable, the administrative savings. Plus, you don't have all this churning. People coming, somebody's dropped off the program because they didn't fill out the paperwork. 2 months later, they get sick and they need Medi-Cal again, and they come forward and they apply, and you got to reprocess it. So it both helps consumers and it helps the states. So that was what we found for Medi-Cal. And now I'm going to turn to the other big subsidy program, which is in the health insurance exchange. Both advance payment of tax credits to pay for premiums and then cost-sharing subsidies for cost-sharing, logically enough. So the rules, now you all should know that the subsidies in the exchange are different than any health program we've lived with before, and for lots of different reasons. One reason is it's not enough to be financially eligible. If you're financially eligible and a U.S. citizen or a lawfully present immigrant, you're between 138% FPL and 400% FPL, you are only eligible if you're not offered affordable minimum value employer-sponsored insurance. If I'm offered ESI, employer-sponsored insurance, that costs no more than 9.5% of household income for worker-only coverage, then I'm ineligible. As long as the coverage is of minimum value, meaning that for the average consumer, the plan would pay at least 60% of the costs within the benefit categories chosen by the employer. Now, the problem is we don't really have data that shows all that stuff. This is a case of, Congress thought, what's a logical rule here? What should it be? And then they looked around and said, well, we really don't have the data that can verify whether that's the case or not. So they're going to try to create some new sources of data. But right now, we don't know who's offered ESI. We don't know how much it costs the worker. We don't know whether it covers 60% or 50% or 90% of the benefits within the employer's category. So what is a data-based eligibility system going to do? So here's what the Fed said in their most recent rules. They said, okay, look, given the situation we have now with not that great data, here's what we're going to do. Number one, the applicant has to attest to whether they're offered ESI that is affordable and of minimum value. And suppose they say, oh, no, we're not offered that kind of ESI, we're eligible. The exchange does whatever data matches it can. Maybe the applicant works for the federal government, and the federal government, they will share their information with the exchange. Well, you know what? In most cases, that data exchange is not going to be enough to determine eligibility. In that case, you grant eligibility based on the attestation under penalty of perjury that the person is ineligible, and within a short period of time, I believe 90 days, you have to audit a certain percentage of the people who've signed up. It's sort of the IRS model. You say under penalty of perjury, here's my circumstances. You pick a certain number of people and you audit them and hope you pick up the problems. That's the approach. So what we wanted to do was to look at the data that we put together, looking at who's going to be eligible for subsidies, and see what can you do if you're a health insurance exchange and you want to do a good job determining eligibility under these rules. And so we identified two strategies, recognizing that you're not going to get all the data that you ideally want, because machines don't always work so great. Cell phones, even I can't. If my 16-year-old, 17-year-old's not with me, I have no idea what to do with my cell phones. I appreciate the ringer going off. So so anyhow, you don't know everything, but you can focus on two things. You could focus on, does the employer of the person who's applying for subsidies offer coverage to anyone at all? Forget about the generosity of the affordable. Do they offer coverage to anybody? Or you could focus on, does this human being who's applying have health insurance right now from their employer? And so we came up with these strategies after using the health insurance policy simulation model, the Urban Institute microsimulation model, where we use census current population survey data, and we do imputations of employer-sponsored coverage from other data sources via statistical data matches. And I'll stop right there, unless you have questions about that in the Q&A, and I'll leave it to your fellow audience members to stone you if you do. But the one thing I need to tell you is that there's not great survey data out there about the affordability of coverage. So we used a couple different methods. We used one method that we knew would overstate affordability and another that we knew would understate it, so that we came up with a range, and the right value should be somewhere in the range. So here's what we found. This is California. These are California data. The earlier data I presented in that last section were national. This is just for California. What we found was the people who will be eligible for subsidies in California in 2014, less than 12 months from now, that 94 to 99% of them aren't offered employer-based coverage at all. Forget affordability, forget minimum value. More than 90% are just not offered ESI. That's who the eligible folks are. And in fact, more than 70%, don't work for a company that offers insurance for anybody. In more than 70% of the time, between 74 and 79% of the time, both the consumer who's eligible and that consumer's spouse work for companies that offer insurance to no one at all. So therefore, strategy number one would say, let's see if we can figure out whether the company that hires this applicant offers insurance to any of their workers, because if we do, we're going to be able to correctly analyze the eligibility for more than 70% of all the eligible folks. Not 100%, but 70% in this ballgame is pretty darn good. It's way better than zero, which is sort of where we're at. So how can we find out which employers offer coverage in the state of California? Well, fortunately, Medi-Cal has been asking that question for many, many years. They have a third-party liability data system. Federal law says every state in the country, as of 2006, had to pass a statute requiring every insurance company, every employer-based plan, every private plan to make available to the Medicaid program information about every single one of their enrollees, so that if somebody's getting Medi-Cal, you check and see, are they also getting employer-based coverage? And if so, let's have the employer plan pay first, and Medi-Cal only picks up the stuff the employer plan doesn't pick up. And so every state, typically they have contractors to mine that TPL data. So the question would be, could we roll up our sleeves and tweak the TPL data to the extent we need to, so that we can get a database that says not all the details about who covers what, but just, does this firm with this employer identification number, this EIN, do they offer coverage to anybody? What about this one? And if you have a database that says, here's, if your EIN is this, you know the company offers coverage. If you're not in the database, you know the company doesn't offer coverage. Then you have a very simple rule. When somebody applies, they have to tell you the EIN that's already in the regs. And so if it turns out their employer doesn't offer coverage, you don't audit them. You focus the audits on the other 30%. And it's not perfect, but it's good enough, and as we know, good enough is perfect, at least according to one book. Strategy number two, completely different. Suppose we can't do the tweaking. And by the way, TPL tweaks, if you have to do IT programming, it qualifies for 90% federal match, CMS tells us. Always a good thing. Not as good as 100, but, you know, pretty good. So suppose somebody is applying. Typically, people are going to apply in October through December for the coverage year that begins in January. So you may have somebody who's enrolled in an employer plan. They're thinking, you know, this is pretty darn expensive. If I'm eligible for subsidy, I'd like to move over into the exchange and get coverage there. So you ask the person when they're applying, right now are you enrolled in your employer plan? If the person says yes, under this strategy, you would say, you know what, you need to document that you're eligible. And here's why. Number one, you want to protect the consumer. So suppose, and here's why I say that. Suppose it turns out that the consumer is wrong and in fact they're ineligible. Well, if you say, okay, you're eligible, you say you're eligible, we're taking your attestation at face value, the person drops their ESI, they go into the exchange, they get advance payment of tax credits to cover their costs, and then 2 months later, it turns out they made a mistake. And in fact, they're ineligible. They've received thousands of dollars of advance payment of tax credits that they have to pay back to IRS. And guess what? The open enrollment period for their employer plan is over. They can't go back to the employer plan, and they don't get subsidies in the exchange, and the odds are they're going to be uninsured. So it makes sense from just a consumer protection standpoint to say, you know what, before you drop this employer plan and make a change that you could come to regret, let's really make sure that you're eligible. And not only is it good for the consumer, it's good for program integrity, because we know that in California, if you look at this income group, 138 to 400% FPL, the people who get ESI in this income group, between 97% and 99.8% of them have affordable ESI. When I say affordable ESI, I mean ESI that the Affordable Care Act classifies as affordable. The point is that the odds are, if you have ESI in California, you are not going to be eligible for subsidies, and it makes sense to say, please prove that you're eligible before we put you on. Now, what if you don't get ESI? Well, in that case, you only have to ask one question. You ask, so how big is the company you work for, roughly? Is it under 10 employees? Is it 10 to 50? Or is it over 50 employees? Once you have that little nugget of information about firm size, you combine that with what you already know about the guy. You know, what was the income? Are they married? Are there children, et cetera? And thanks to the kindness of the California Health Care Foundation, you will know how likely you are to be offered employer-sponsored coverage in California. So we've gone through, I'm not going to go through this in detail, but Matt Butkins and his team of mathematicians and and economists have gone through and divided up all income-eligible Californians into like 20, 22 different groups. And for each group, they've said, what are the odds that people in this group are going to be offered employer-sponsored coverage? And how many people are in the group anyway? So, for example, suppose you don't work at a firm with more than 50 people. In fact, suppose that you're at a firm with, say, between 10 and 50 people. Say you're married, but you don't have any kids. We know that you have a 13% likelihood of being offered employer-sponsored coverage. Now, suppose there's somebody else who comes in. They make more than $29,000 a year. In fact, their MAGI is over 300% FPL. They're married, but they don't have dependent children, or maybe they do. In that case, you have a 36% likelihood of being offered ESI. So when it comes time to audit, people in that first group are going to get a certain number of audits. So people in the second group are going to be 3 times as likely to be audited because they're 3 times as likely to be offered employer-sponsored coverage. So it's a way to say, look, if we have so many dollars we're going to devote to audits, let's target those audits at the places where it's most likely to pick up an ineligible person. Or another way of putting it is, if we want to detect a certain level of ineligible people, what's the cheapest way we can do it so that we don't have to charge an arm and a leg for people who are using the exchange for coverage? So to summarize quickly, what we found was more than we expected. You really can use prior year income data to help establish current eligibility for Medi-Cal in a lot of cases and achieve great streamlining for consumers and administrative savings for states. Now, to be clear, income data is not the only source of data that can facilitate this kind of eligibility determination. CalFresh data, for example. If somebody gets CalFresh, in many cases you know 100% certainty that that person is income eligible for Medi-Cal. In other cases, it just drops down to 90%. So there are other data sources from other public programs. CalWorks is another. But what we wanted to focus on was income data, and what we found is that data matching could potentially be a very valuable tool from the consumer perspective and from the perspective of state administrative costs. We also found that even though we don't have all the information we would like about employer-based coverage, we have enough from which Health Insurance Exchange can do a responsible job of estimating eligibility. And with that, I'll stop and turn it over to my friends from the Department of Healthcare Services, and look forward to your questions.
Hello, so I'm Renee Mahler with the California Department of Healthcare Services. And first, I wanted to say thank you to both CHCF and to Stan Dorn for this great work. It's really appreciated. And just a couple of comments is that, as we're embarking upon policy decisions regarding healthcare reform and looking at the provisions under the Medicaid program, this is really timely information for us. As we're looking at developing standards regarding reasonable compatibility, because as Stan points out, one of the things that we had hoped for in terms of federal guidance was to give us information on, like, how do you set that standard for reasonable compatibility? And so this information helps to give us a framework from which to work from and to think through as we're looking at the work that we're going to have to undertake in the Medi-Cal program. Because, again, we do have things to think about in terms of enrollments in the Medi-Cal program. Today we cover approximately, it's estimated we'll cover approximately 8 million individuals this fiscal year under Medi-Cal, and as we look at healthcare reform and the expansions and the simplifications, it's estimated that we're going to add somewhere between 1.5, maybe upwards to 2 million individuals into the Medi-Cal program. So we need to think through the fiscal implications for that, and then also on the administrative side, what will that mean for us in terms of our administrative costs and efficiencies in terms of the work that we have to undertake. So this is really, really interesting, and it also gives us some thought in terms of looking at this national data and how the national data might be used to help inform some of the decisions that we need to make. One of the questions that I do have for Stan, if he could maybe touch on a little bit, is in looking at that national data, and if you were to take from that national data set, data that is specific to California, do you come up with some of the same reliability standards in terms of individuals that would still maintain their eligibility based upon those coverage months that were identified?
It's a good question, and we tried to answer it in two different ways. As I mentioned earlier, the survey that we looked at was the SIP, the Survey of Income and Program Participation, and we looked at California respondents inside the survey, who were, a pretty large group, and we found there were some differences. The differences mainly involved how much part-time workers are paid. It appeared from the SIP that part-time workers in California are paid a little bit less than in the rest of the country, but we didn't know whether that was just small sample size, just sort of the luck of the draw, or whether that reflected reality. So then we did another methodology. We took the SIP and we reweighted it to reflect the characteristics of Californians, and there we found absolutely no difference. The first method found not much of a difference. The second method found absolutely no difference. So the long and the short of it is, based on what we could tell using these two different methods, it's the same general level of reliability in California.
Okay, very good. And then, I don't know if you have thoughts, comments?
Oh, hello. As Renee alluded to, we're working fast and furious with the Health Benefits Exchange Covered California, along with their the Accenture CalHERS team. And I think that this data that Stan's presented, both here as well as in his paper, is really going to, like Renee mentioned, is going to inform some of our decision-making specific to the verification plan that the department's going to need to submit to CMS soon. We are actively working on that verification plan. I think one of the couple things that really stood out to me in both the paper as well as the presentation was this idea of pursuing the administrative renewal or verification of income eligibility based on the likelihood that the person continues to be eligible, not only based on the age of the verification data from the federal hub, but also it was the age of the data, as well as the the level of income. So where they are along the spectrum of 0 to 138% of the FPL. So that's really something that we're going to have to think about in terms of are we going to require at some point between maybe 100 and 138 of the FPL, and considering the data coming back from the federal hub and the age of it, are we going to require some sort of administrative verification of income versus assuming that the person is under the 138 FPL for the next renewal period or eligibility period, and granting them eligibility. So I think that's what really stood out to me in the results, and something definitely to think about. That's about it, all I had.
Great. Thank you very much, Renee and Robert, for your comments. And I'd like to open it up now to questions. I'm almost certain there are some clarifying questions that some of you may have for Stan. So I'm going to ask first, if anyone has things or would like to see a slide again or has questions about how the numbers work, feel free to ask those.
My question is it probable that the reason why you now can use a standard of reasonable eligibility without having income from the previous year is that we have been in such a tough economic time that if a person reasonably had no income from the previous year, that it was the likelihood that they probably don't have income this year is really relevant. So was that one of the variables that you factored in terms of the dynamics of determining reasonable eligibility?
Well, we looked at the facts that were in the survey, and the survey took place in 2009, 2010. But remember, it's not just about people who had no income. It's about people who had income at 100 to 120% FPL. And what we found was, income goes up, income goes down, but depending on the two factors we just heard about, how low was your income last year and how long has it been since the data we're fresh, you can assess what your likelihood is of eligibility right now. Now, if economic circumstances change as we hope they will, and we suppose we go into a booming recovery, then that would mean that this year's income might be higher, and therefore the percentages might change. So at that point, it might be reasonable for the state to say, you know what, instead of saying your income last year had to be under 120% FPL, it has to have been under 100% FPL, because we know more people's income are going up.
But do we know that?
Do we know what?
That more people's income are going up? How do you-
Yeah, overall,
Okay,
in the
okay.
country as a whole.
Okay.
But, there's a problem, which is that survey data aren't instantaneous, right? I mean, SIP ran in 2009, 2010. It's still going. You couldn't access the data for a little while. So you're raising a really good question. We should think about, how do we tweak these business rules based on changes in macroeconomic conditions?
Yes.
And it's a really good question. I'm going to have to think about
Because the estimate, I work for Senator Noreen Evans, and so the estimates that we have seen is that, and from the governor's budget, as I understood it, is that we're still looking at a 7-year period of very, very slow growth.
Okay.
So.
Well, I hope that's wrong. If it is true, then these numbers are going to continue to be applicable. But if the economy starts to pick up again, and I were running a state Medicaid program, I would lower those income thresholds a little bit to account for the fact that we may be seeing rising incomes.
My name is Julie Stone. I'm with the California Association of Public Hospitals and Health Systems. And recently, there was a woman, and I can't remember what university she was from, but she released a paper that showed that it was about churning, the issue of how many people's income churns. And so I was thinking about your analysis of the SIP data compared to what she showed, which was people around the borderline between 138% of poverty, and a large number of them are shifting, and their income is shifting and going in. So how do you address that issue around churning and people's incomes fluctuating with the SIP analysis that you did?
Yeah, we actually used the same data to analyze churning. We did a paper a couple of years, maybe a year or two ago, on churning. And it's true, you do have incomes that change. So if you're looking at folks who had 120 to 138, in the first couple months of the year, you've got 36% of them who have gone above 138% FPL. That's a significant churn. But from the Medi-Cal perspective, there's a 64% likelihood that that person is eligible in January, February, March, and April. And if the person says, hey, my income is at X and X is at 130% FPL, that's enough to verify your eligibility. So now later on in the year, September through December, it doesn't make that 60% cutoff. So if the state wants to use a 60% cutoff, it might say, you know what? And here's the other thing. We gave you the best estimates we could within sort of chunks of people in time. So here we're looking at 120 to 138. That's a pretty narrow chunk. September through December, that's another chunk. We can't tell you, well, December, it's this percent, and September, it's that percent. We can't tell you people between 120 and 125, it's this percent. Between 130 and 138, it's that percent. We can just say for the group as a whole, for the months as a whole, this is the likelihood. Am I making sense? So if I'm a state and I'm going to use that 50% threshold, I could still say, you know what, when it comes to November and December, if the person's income's in the upper half of that bracket, if it's at 130 to 138, I'm going to ask for documentation just to be sure, because we can't say it's definitely more than 50% for that particular subset. So the long and the short of it is, you're absolutely right, Julie, there is churning, but it's also true that prior year income can still be helpful. Now, we also did a bit of analysis in the project looking at what we know about current year income. We have quarterly wage records for many people. We have new hires reports for many people. And I was expecting those to really have a dramatic impact on the reliability of income estimation. And it has an impact. Instead of being, 50%, instead of being like 56 to September through December, if you know the person's first quarter income and they haven't had new hires, it might be 59%, or 61%. So there's some additional precision that you gain with that current year information.
Hi, Patrick. I work for Senator Padilla. This is a question. I'm not sure if this is for Renee or for Stan. But if we're using existing data, do we have any estimates of how that will expedite the enrollment process from the time of application to the actual receipt of a Medi-Cal card? And then also, secondly, do we know how many people we don't have data for? Is that
I mean, one of the things about the enrollment and the data and looking at the availability of that information is, the standards that we're going to have to set in place in terms of reasonable compatibility and what we're checking against. The goal under ACA is that people have their eligibility determined promptly and without undue delay. So as we kind of think through, like, say, using some of this information, depending upon the timing of when someone is applying for the program, looking at some of these income standards, and how we'll define more precisely that reasonable compatibility standard will then kind of determine, will there be additional information we have to get from individuals, how quickly can they turn that information around to us, and or what other data sources that we have that we believe are reliable enough for us to match up against that before we actually reach out to that person. So it's a good question. Today we have certain timeframes in the Medicaid program in which to determine eligibility. This is a new frontier for us, so we don't really have good statistics right now to say it will take this amount of time versus that amount of time. That's going to be something that we're going to be evaluating once we roll out healthcare reform and looking at the different systems that we're going to have available to us in terms of determining eligibility. I don't know if you want to add.
A couple thoughts. I agree with everything Renee has said. A couple things I would add. The feds have said that exactly the standard she mentioned, without undue delay, promptly, but they've also said, we're giving you all this 90% money to build a wonderful IT system for eligibility determination. And if you want to take this money, you have to agree to live by various standards. And one of those standards is, whenever possible, you have to determine eligibility in real time. So whenever possible, that consumer goes forward, fills out that application form. If you can do data matching that verify it, then you can say right then and there the person is eligible. Now, it's a new world. We don't know how often that standard is going to be met. I don't think CMS expects it to be met, on day one for, even 60% of the people who are applying. And this is the first. And as I say, I'm so grateful to the California Healthcare Foundation for sponsoring this study, because this is the first work that starts to say, well, given data sources X, Y, Z, how useful is it? What business rules can you apply? How many people can you help? So we don't know how many folks are going to have these records. I can't even tell you for the stuff we looked at how many are going to have these records. I can tell you 75% of the poor uninsured file federal income tax forms. I can tell you that people whose income was X have likelihood Y of being eligible right now, but how many people will the two match up for? We don't know. People who don't file federal income tax forms, how many are receiving CalFresh? And there may be a fresh, pardon the pun, income determination in those program records that you can use to verify eligibility. So, it's a new frontier we're moving forward on. And as I say, one of the reasons why I'm excited to be here is I know that California is again saying we are going to be one of the nation's leaders. This is a new ball, and it's, this is the home of Silicon Valley, right? I mean, which state should be in the lead with using data to qualify people for eligibility? Louisiana? I don't think so. It should be you guys. And so I'm thrilled to be here to help you think through how are you going to wrest the mantle of leadership away from Bobby Jindal and his crocodiles in the Louisiana swamps. Bring it back home to California.
Over here. Oh,
Real quick.
Okay.
More of a statement. My name's Christian Turner. I'm the Chief Information Security Officer over at the Employment Development Department. Last year, some legislation was passed that gave the exchange access to our data, and our data consists of unemployment insurance claims, disability insurance claims, quarterly wage data, as well as the employer data. And we're working with them, with the exchange currently, on how to get that real-time access, because it doesn't exist today. But the target is to do real-time within 20, 30 minutes of application start. So it's a pretty aggressive time frame that the exchange has given us. And my department is only one of dozens that are working with them. So we're getting closer, I think.
yeah, it is clearly the build, and Robert's probably in the thick of it every minute. It is very ambitious. And I should say also that, unfortunately, many of our exchange colleagues weren't able to be here today because they're getting more guidance than off in Baltimore. But we will take, if there are specific questions for our exchange folks, we'll take those back. Yeah, go ahead.
Hi, I'm Dennis Gilliam. I'm retired now, but I have a long career in both welfare and health programs in the state. Early in my career, I was once involved in redesigning the state's welfare reform to simplify it after the early Reagan administration, which had tripled the size of the form to make it more complicated and more difficult to complete, with malice aforethought in order to keep people off the rolls. As we know, based on budget constraints and the political philosophy of elected leaders, the willingness of government to accept people into government-subsidized program waxes and wanes over time. How will data mining prevent that kind of phenomena from happening, if it will at all?
Ben?
Wow.
Do you have thoughts on that?
What a great question. You can't prevent the waxing and the waning of the moon. You can't prevent changes in political climates and changes in personnel and administrations, and so there will always be changes, but the question would be, do you establish regulations at the state level? Do you establish business rules? Do you establish institutions that strike a reasonable and appropriate balance that try to protect program integrity? I mean, the idea here is we should be able to use data to accomplish three things at once: make it easier for consumers to enroll, make it more efficient for the state to determine eligibility so that a higher percentage of taxpayer dollars go to benefits rather than administration, and determine eligibility accurately. It should be possible to have all three policy goals, efficiency, program integrity, and participation levels, be met at the same time. There are always going to be some trade-offs, but you want to pursue all three at the same time. So it seems to me, right now, it's a new era. We're building a new world, and you want to build that new world the best you possibly can to keep all three of those goals in mind, and then just you try to defend it as time goes by. If there are people who come along and want to try to shift the balance, but just do your best, build it as best you can, and then guard it.
Renee, did you have a comment, and then we'll go to you?
I was just going to echo that, and I think what'll be really key is looking at the data, making data available to people, and using that data to help inform future policy decisions. Sometimes, the work that we do, people think it's in a little black box, but with some of the provisions that came out from the ACA in terms of transparency, having a data verification plan, having your eligibility rules being transparent and making them available to the public, I think all of those things collectively and the data that we collect will help to inform individuals so that as we are making decisions, they can be well-informed decisions and hopefully meet the needs of many people, because there's many different masters out there that we have to meet the needs of. And again, we have to balance coverage and enrollment into these public programs and making sure that we're being responsible stewards of the public dollar as we're administering these programs.
Hi, I'm Sharon Angston with California Forward and working on the realignment stuff. Used to work for CDCR up till about a year ago running healthcare. So I have a huge concern about offenders and healthcare. And I think with the jails being able to suspend for the period of time they're in jail, that's great. But for inmates in CDCR prisons, what we were able to do is a very limited amount of eligibility stuff because it was so expensive to do. It took so much work. I'm assuming now with this kind of ability, you've got one agency who, has all the records to the extent you can. And these guys are in prison, people are in prison, so they're not going to have a huge amount of income, that this will be simpler so that, because I think this is one of the bigger issues. These guys get out, and I'll tell you, my mental health guys, the minute they hit the street, it's like they lose their meds, and particularly for serious mental illness. Mm-hmm. And so what happens is they have huge health problems and mental health problems and substance abuse, and they go right into jail. And so getting that eligibility determination quickly, being able to get them services right away and coordinate care, because I don't know how many counties have said, we get this guy who shows up, we have nothing. And so they have absolutely no idea what this person's taking, and I'm assuming all of this will help that significantly so that most of the folks that are in CDCR, and 25% of our guys had mental health issues on our caseload. That those folks, we can get them connected quickly and be able to have them eligible, and that we can get information to the providers in the counties. Is that a fair
I wouldn't take it that far in terms of some of that health information. I think from the perspective of looking at eligibility and getting them into coverage, that's what our goal is to get people into coverage promptly and without undue delay. But I think there have been those discussions about that bigger picture and that bigger desire of having not just eligibility information for public programs, but also having health information and how we make that available to people, across the healthcare continuum. And that won't be solved with this eligibility system, but it is certainly something that's out there and in the minds of many people.
I think you're right, that making it easier to sign people up for Medi-Cal as they're leaving prison could help things a lot. Obviously, mental health access in Medi-Cal isn't necessarily the greatest in the world, but if it's a heck of a lot better than nothing if you're uninsured. And now it's interesting, it's a little known fact, if you're in prison, you actually can be eligible for Medi-Cal. Federal matching funds won't pay for your health care services by and large, but you can still be eligible for Medi-Cal. So that means when the person is still in prison before they've been released, you can sign them up for Medi-Cal. They can have their eligibility established. Not only that, there is an exception to the rule about banning federal matching funds for prison health care, and that applies to inpatient care and institutional care where the prisoner is off the prison grounds for 24 hours or more. And so there are a good half a dozen states in the so-called flyover regions of the country that have shifted their inpatient hospital costs in their state prisons to the federal government via Medicaid. And my friends in California, you're looking at how many of these inmates are going to be newly eligible adults with incomes under 138% FPL qualifying for 100% federal dollars. If you're thinking about the state budget, this is an area you really want to think about. So what I would think about if I were working on these issues in California is trying to figure out how can we shift prison health care costs off prison grounds for inpatient care and institutional care, draw down federal matching funds, save a lot of money in the prison health care system, and at the same time sign these folks up for Medi-Cal before they leave, and if possible get them hooked up with a case manager or a primary care provider to help, who's knowledgeable about mental health and substance abuse treatment, so that when they get out into the community, they can immediately get hooked in for treatment and get their needs met. I think I'm so delighted you asked that question, because I think it's an area of where really great progress is now possible.
And to add to that, we are doing that.
All right.
We're doing that today in terms of our federal prison inmates and working with CDCR in terms of having individuals eligible either under the Medi-Cal program or through our local, the low-income health insurance programs. And then we're also looking at opportunities, because we do have state law today that does allow for the provision of this limited exception of Medicaid coverage for individuals that are either in state prisons or in local county jails. So we're working through the policy development for the local county jails, but we are doing that today. Pardon?
We also have medical parole.
Yes, and also with medical parole. So all of those things we have been working, because I do think we are masters at maximizing federal funding under the Medicaid program.
Yeah, my name is Paul Melvin, and I work for the Employment Development Department. But in the past, we've dealt with a lot of data sharing, confidentiality issues. And because of the different natures of the different federal programs, state programs, et cetera, who all have different rules and regulations, has anything been set that allows you to do individual data sharing on individuals, or is this just being done at the group level to get probability statistics?
Well, the research was done sort of at the group level. It was done with federal survey data where you don't know who somebody is, but here's respondent 233, and here's all the things we know about them. But as you actually are implementing the thing, it's all about the individual data. It's all about, Mrs. Gutierrez is applying and what was her income last year. And your question is absolutely well taken. You need to sort through what are the applicable legal requirements, also what are the policy provisions you need to think about in terms of safeguarding privacy, data security, huge issues. And they've been dealt with in lots of different contexts, and there's some really wonderful regulations in the exchange regulations, the federal exchange regulations. Some really great thinking has gone into that, but you got to sort through all those issues. What's nice is we're not beginning from a blank slate. And so the state for a long time has had the EVE system up and running, or income eligibility verification system, where a lot of different sources of data come in and can be used to help establish eligibility for Medi-Cal, for CalFresh, CalWORKS, et cetera. There's going to be a new federal data hub. Hopefully it'll do great things. We'll have to see. But the nice thing about it is that way the state just establishes a relationship with the one federal data hub, and via that relationship, you bring in information from the Department of Homeland Security, the Social Security Administration, the Internal Revenue Service. The Fed's, hopefully going to do some other things. There's talk about bringing in payroll records, right? Small firms. There's a couple payroll processing firms that do payroll for a lot of different small companies. Maybe we can get those data. There's The Work Number. Anybody here heard of The Work Number? It's a private vendor that gets a lot of wage records that it shares for a pretty price with public benefit programs. So there's a lot of different possibilities, and the hope would be you just do one data sharing agreement and you can access all that stuff by the federal data hub. That ain't going to be happening in the next 12 months as much as we would like. So I think the smart states, and this is among them, are thinking about a state data hub along with a federal data hub. But I'm really glad you asked that question. You need to work through those things.
Hi, I'm Lisa Morawski with the Assembly Appropriations Committee. Stan, I'm not sure if you've looked at this as part of the Medi-Cal research, but what is the impact you think on total Medi-Cal enrollment in terms of, I think you talked about 28% of people losing eligibility, of adults losing eligibility year over year, and a lot of them are still eligible. So does it have a major dramatic impact on Medi-Cal enrollment, or is it more just reducing churn of people coming on and off the program?
Good question, and we haven't looked at that in any specifics. Whether that 28% that was for kids, only half of those kids were eligible, but for the adults it's higher. It's like for categories of it. Well, it'll all be in the paper. That'll be released at some point soon. This is a PowerPoint presentation. We've done one paper already that's in your materials. Keep an eye out on the California Healthcare Foundation website, as I'm sure you all always do, and there will soon be this new paper coming out that'll give you these numbers. And so all the studies are going to be there. So I think the short answer is if you make participation easier, you're going to have more people who are eligible to participate. So that means you're going to have more folks on the program. And also, if you make it easier to stay covered, you have less churning, which means you have, that doesn't affect necessarily the numbers as much, but it means instead of having the ridiculous specter of eligible people not completing paperwork, bouncing off the program, coming back 2 months later and applying again. I mean, it's unbelievable, the percentages. It depends by state, it depends by program, but very high percentage of folks are in that revolving door. That's going to be cut down. So, but I think the long and the short of it is, with the CHIP program, and let me just to step back for just a minute, we have 6 million uninsured kids in this country. We have 85% of eligible kids who are enrolled. If the CHIP program, if children's Medicaid and CHIP was as successful in enrolling people as adult Medicaid is, instead of 85%, you'd have 67%. So instead of 6 million uninsured kids, you'd have 16 million uninsured kids. That's the difference between 67% and 85% take-up. It's huge. And so what this means is if California and if other states can get the enrollment process and the retention process to make sure that eligible people get on and stay on, it's going to have a big impact in the number of uninsured.
Okay. I want to thank you all for coming. I want to thank my colleagues Karen and Danny, who are out in the hallway, for making this happen. They always... And Karen's colleagues who are also here, they always make this come off as though it were easy, and it is not. And also particularly to thank Renee and Robert for being here from the department, and Stan for coming out from DC to talk to us. We will, as Stan said, one of the pieces from this project is published. The other one is forthcoming, and we will make sure you receive notice of it, the one that we spent the majority of our time on today. And then there will be some additional research pieces coming forward in the next few months. So stay tuned, and thank you very much again for being here.